I'm extraordinarily pleased to be able to introduce this year's Master Surgeon, Dr. Lena Naolitano. I will be brief in her introduction so as to not take her time. After all, you're here to listen to her, not me. Dr. Naolitano is the Joyce and Don Massey Foundation Professor of Surgery at the University of Michigan. She's the Chief of Acute Care Surgery, Chief of Trauma and Surgical Critical Care, and the Associate Chair for the Department of Surgery. Lena's service nationally has been impressive. She has served leadership roles in East SCCM, the Surgical Infection Society. She's a director of the American Board, chair of the Board of Governors for the ACS, and previously served as secretary and member of the executive committee. Lena represents the AAST on the Trauma, Burns, and Critical Care Component Board for the American Board of Surgery, has served on the Board of Managers, and chaired the Critical Care and Education Committee. She's been a prolific investigator, serving on PI for numerous grants, and has authored over 200 peer-reviewed publications, as well as 90 book chapters. She's a fabulous educator and won a teaching award every year she was at the University of Maryland. She's received numerous awards, including the Packard Medal by USUS and the Association of Women Surgeons Distinguished Member Award. I first met Lena in 1997 when I moved to Baltimore. She was clearly a star that was rapidly rising. I immediately embedded her into our fellowship as much as she would do, and soon thereafter made her the fellowship director. She ran the university's surgical ICU and completely revamped both the fellowship and the intensive care unit. She left a few years later to go to Michigan, where her trajectory has remained incredibly steep. As we've defined acute care surgery, trauma and general surgery have become dominant. And to a certain extent, I think we've lost our critical care roots. After all, it's where most of us started. And so when I thought about who it was that would be the master surgeon, I made a conscious decision to ask somebody that was prominent in the field of critical care. After I made that decision, the choice was, frankly, very, very easy. I can think of no one better than Lena. She's been perhaps the best example of a surgeon who has led critical care in clinical care, education, and investigation. We all look forward to many more years of Dr. Naolitano leading us. Ladies and gentlemen, Lena Naolitano.
Well, good afternoon, everyone. First, I'm going to cry. I want to thank Tom especially. I worked for Tom for a decade, and this is a very special honor for me to be here in front of you, but most importantly, to be chosen by Tom, a prior boss of mine, a prior leader, clearly a leader of multiple trauma organizations as president and vice president, someone who I look up to, and I'm incredibly grateful that he chose me. So, we're going to look at a critical care topic that really has sort of come upside down over the last decade and look at severe ARDS management in the ICU. One of the most important changes that has occurred in the last decade is a true change in the definition of ARDS. As you look at this slide, acute lung injury here, PF ratio less than 300, was included in many of the clinical trials, and there was no definition for severe ARDS. And I've really focused my talk today on severe. When we look at ARDS and pooled mortality studies, it included ALI, moderate ARDS, and severe ARDS, and overall mortality was 44%. The new definition in 2012, the Berlin definition, was quite challenging in that it now includes a timing within 1 week of known clinical insult. It includes 3 topics here of ARDS: mild, 200 to 300 PF ratio, so acute lung injury is gone; moderate ARDS, 1 to 200, and severe ARDS, less than or equal to 100. And I think what I'm really wanting to leave you with today is that it's important to provide an evidence-based algorithmic approach for the care of these patients in order to achieve substantially good clinical outcomes. After the Berlin definition was defined, they actually applied that definition to clinical and physiologic databases of previous RCTs that had been performed. And again, if we focus on severe ARDS, you'll see here that mortality rates were high at about 50%. Hopefully, I'll convince you by the end of this discussion that an algorithmic approach with rescue strategies can lower that mortality rate. And this is our data from the University of Michigan. I'm really privileged to be part of a huge group of clinicians and surgeons that have expertise in ARDS management. And again, if we focus on severe ARDS with the new definition, a PF ratio less than or equal to 100, you can see that our mortality rate of 32% with a substantial patient population here is actually quite a bit lower. Looking at the rescue strategies for severe ARDS, many of them do not have type 1, level 1 evidence in large RCTs, but I'm going to share with you the evidence that there is now and give you my projections of where we're going for the future. Along with the new Berlin definition of ARDS, there's been a strategic approach to actually link rescue strategies with the severity of the ARDS and to preserve our high-cost, high-technology strategies for the more severe ARDS patients. The most recent trial data that we have in terms of ARDS outcomes comes from a European trial, the Lung Safe trial, and although this is not yet published, it is available since it has been presented at ESICM. This was a tour de force. It was a global cohort study of over 12,000 patients with severe acute respiratory failure, of which a cohort had ARDS 2,579 patients. Of those 2,500 some odd patients that met criteria for severe ARDS, 380 met the criteria for severe ARDS by the new Berlin definition. That's 21%. You can see that they are a younger patient population. And what's most notable, since this is a recent clinical trial, is that the recruitment strategies, neuromuscular blockade, steroids, prone positioning, and ECMO were used as adjunct strategies, as rescue strategies in a large portion of the patient population, particularly when PF ratios were less than 50. Again, focusing on the severe ARDS cohort, you can see that mortality rates for severe ARDS in our current time frame, not older studies, this is recent clinical trial, 46%, quite high. Contrast that to mild ARDS and moderate ARDS, and you can see that the death rates there were about 18 to 20%. What was really noticeable from the Lung Safe trial was that rescue strategies were used in sort of an odd pattern where pharmacologic strategies were used a little more frequently, here neuromuscular blockade, but higher PEEP and prone position and particularly ECMO were used infrequently. And a very important finding was that high PEEP was not used commonly. Most of the patients, again, had very low PEEP, less than or equal to 12. So to bring you through our evidence-based algorithm that we developed at the University of Michigan that really fueled our interest and our scope of practice in this area of investigation, I'm going to show you one of our recent patients who just had a 1-year anniversary of her ARDS course at the University of Michigan. This is an 18-year-old young girl who had lupus in a very advanced stage, who was in our medical ICU and who was in hospital for plasmapheresis, and we got called by the medical ICU to come and evaluate her for a possible ECMO evaluation. And again, you can see that the severity of ARDS here by her blood gas, 727/6847 on an FiO2 of 1, is quite severe. Most noticeably, she was in septic shock on 3 vasopressors. Her sources of sepsis were a plasmapheresis line and pneumonia. She already had acute kidney injury. She was anuric. And we have the ability in our institution, surgical critical care has the ability to initiate CRRT, something that I felt very strongly about when I went to the University of Michigan based on the approach at shock trauma. We took over her care. We started the standard management strategy that you see delineated here, but the medical ICU team had already provided that treatment of the underlying cause, supportive ventilation. And similarly, we were limited in providing a restrictive fluid strategy because she is also in septic shock, and everyone is aware of the FACT trial from ARDS-net that showed a fluid restrictive strategy was associated with decreased ventilator and ICU days. She was already on low tidal volume ventilation at 6 cc's per kilo, one of the pivotal ARDS trials that showed a mortality advantage, and she was already on 20 of PEEP. And so we know from the initial ARDS-net trial that higher PEEP was associated with improved outcomes as well. So the medical ICU team was doing a good job at preventing volutrauma and preventing atelectasis trauma with low tidal volume and high PEEP strategy or an open lung approach. We have a strategy that we've employed of how we use rescue strategies, particularly in severe ARDS, and she meets this criteria at present for severe ARDS with her PF ratio less than 100. This is our abbreviated version. And then for our residents and fellows, we have this on our online surgical critical care manual so that the evidence behind this algorithm is present within the algorithm itself on the back page. So here she was already on low tidal volume ventilation, lung protective ventilation. She was already on neuromuscular blockade by the medical ICU team. The level 1 evidence supporting neuromuscular blockade comes from the ACURASYS trial, a prospective randomized trial of 340 patients. Interestingly, this was a cisatracurium infusion with no neuromuscular blockade monitoring. Nonetheless, there was a significant effect size and mortality was reduced from 40.7% to 31.6%. There was reduced barotrauma, and there was actually no long-term evidence of ICU paresis. So this is an early standard approach to achieve ventilator compliance and avoid ventilator dysynchrony in severe ARDS, short-term neuromuscular blockade in the Papazian trial, and then in meta-analysis with 2 other trials was actually effective, and it is part of our early rescue strategies for severe ARDS. What we were struggling with was, should we do a recruitment maneuver for this young woman who has severe hypoxemia? And so recruitment maneuvers are a bit more challenging in terms of evidence. It is next on our algorithm. And when we look at recruitment maneuvers, the evidence from Gattinoni and colleagues and a number of other US and European investigators do show that with increasing recruitment with higher levels of PEEP, here 0 PEEP, here 40 PEEP, you can actually reduce condensed or non-aerated lungs significantly from 60% to about 10%. Similarly, here in this publication from Gattinoni, in one patient it required a plateau pressure of 60 and a PEEP of 25 to actually recruit 87% of the condensed lung, and at a plateau of 40 and a PEEP of 17, only 35 was recruited. In a summary of 20 trials that have been done to date, not all RCTs, it is clear that recruitment maneuvers are associated with improved oxygenation. And so it is a beneficial strategy to employ early on for patients who have condensed lung volume. And you only have to be aware of hypotension and desaturation that can transiently occur and then will improve as soon as the recruitment maneuver is released. It is important to recognize that just simply going up on PEEP in a graded approach is not going to achieve the same benefit in recruiting condensed lung as a single recruitment maneuver. This top line is PF ratio after a single recruitment maneuver with increasing PEEP, and the bottom line here is just increasing PEEP, and you can see the significant difference. So we employ an open lung approach that uses a recruitment maneuver, and whether we do 40 of PEEP or 30 of PEEP is dependent again on the ventilator settings and the hemodynamic stability of the patient. We actually change to a pressure control or a pressure mode of ventilation. We optimize PEEP. We watch compliance on the screen on the ventilator, optimize compliance, optimize PEEP, watch oxygenation improve. We then come down on PEEP, find our critical closing pressure. That's when oxygenation and compliance drop. and then go right back up by 2 or 3. And this open lung tool is now prevalent on many ventilators. So we use the Draeger, but many of them have it dependent within the ventilator circuit itself. You'll notice, however, though, that recruitment maneuvers are not part of the rescue strategies that are listed as part of the new Berlin ARDS definition and rescue strategies that go along with it. And we feel in our patient population, since we really receive mostly severe ARDS patients, that patient population does warrant it. But here's a caveat that's incredibly important. This patient was on 3 pressors, severe septic shock. We immediately did a bedside echo in the ICU, one of our vital signs. And this patient, actually 18 years old with septic shock, had severe biventricular failure with an EF estimated at about 10 to 20%. And this is presumably related to septic shock and myocardial depression. She had no abnormal cardiac function prior to this episode of sepsis. And so doing a high recruitment maneuver in her was problematic. So we moved next down on our strategy, and that was inhaled nitric oxide. I think this everyone is widely aware of. Inhaled nitric oxide is a selective pulmonary vasodilator that can potentially improve intrapulmonary shunt, but sometimes actually worsens shunt, so you have to be careful. Not all are responders. There is no question that nitric oxide improves oxygenation. It has no impact on mortality. And it is in the list here as a rescue strategy for severe ARDS. And so we started Michelle on inhaled nitric, and she was not a responder. We used 10 parts per million, and unfortunately she did not respond at all. So time is of an element here in our algorithm, in that as time goes on, severe hypoxemia is still present, and if you can't improve oxygenation quickly, there is the potential for anoxic injury. Our next algorithm is prone positioning, and prone positioning is a strategy that we employ very quickly at the bedside. This is the concept of having a baby lung on top of a consolidated lung, and if you flip them prone, you improve VQ matching to the anterior aspects, but probably more importantly, you can recruit the posterior condensed lung with your high PEEP. So the posterior dependent atelectasis, if you have the benefit of a CT scan, is optimizing a patient who would potentially benefit or be a responder to prone ventilation. Now, early on in the mid-200s, there were a number of meta-analyses, all with very small trials, as you see here, that did show, just like nitric, that prone positioning did improve oxygenation, but prone positioning had absolutely no impact on mortality. But again, as I relayed to you earlier, one of the problems with ARDS research was that ALI and all forms of ARDS were lumped together, and so seeing the effect for severe ARDS was not possible. It was actually Gattinoni, again, a wonderful, smart Italian, who decided that we should look separately at the ARDS cohort and exclude ALI patients. And they began to see a signal that there actually was an impact of prone positioning on improving mortality. And he pulled all of the prospective randomized trials, pulled out only the severe ARDS cohort of PF ratio less than 100, and you can see here that there was actually a reduction in mortality with prone position. And this was hypothesis generating and led to the Perseva trial. The Perseva trial was published in the New England Journal in 2013, and it demonstrated, after enrolling patients with severe ARDS here before the Berlin definition, PF ratio less than 150, they randomized patients to 16 hours of prone positioning till improvement, and a mean 4.4 prone positions per patient compared to just supine position. They had to look at over 50,000 admissions to enroll 474 patients. And the effect size here of prone position was quite remarkable. The effect size was huge. At day 28, the mortality was reduced by 58% in the prone position cohort. And by day 90, it was reduced there by 52%. So a persistent mortality benefit, a persistent survival benefit through day 90. This was adjusted for SOFA score, so a very well done trial. So we're fond of prone positioning at Maryland, and I'm fortunate to have a great group of staff nurses who developed a technique that's very easy and allows you really to do a quick flip, as we call it. It takes 4 people, 2 sheets, hands underneath, and just basically flip the patient like a pancake. You can see in the end here, they're very comfortable on their belly, their back is readily available, and there's just a sheet covering their bottom. We use 2 saline bags to support the eyes, which is very important with their head turned to the left or the right. And then when we flip back, it just takes 2 staff people. Again, the same strategy of using a sheet to just flip them. And we do the same thing. We've now changed. We used to do 10 to 12 hours a day, and now we do 16 hours a day. But so we can prone very quickly, whether they're on CRT or not, it doesn't matter. We prone on ECMO. The staff are very comfortable. We've moved away from using the striker frame in part because of positioning and pressure points, and I would caution against the use of the prone bed. I sort of feel like this is not a good place to have a critically ill patient. So prone positioning is a big part of our strategy. So for Michelle, the person that I just showed you, Michelle did respond initially to prone positioning, and she had an improvement in oxygenation in the first 12 to 18 hours, and then she began to deteriorate again. We then consider pressure control modes. She was on volume control ventilation at low tidal volume. And whether we do it by APRV or oscillator or some other pressure control strategy like bi-level, really to me is no different. I want to make a mention of a trial that's ongoing because this is something hopefully we'll see for the future. And we thought about this for Michelle and decided against it again because of her severe septic shock with severe hypotension requiring multiple pressors. And that is this concept that maybe we should titrate PEEP by esophageal pressure. Danny Talmore is leading this effort at the Beth Israel Hospital in Boston. He did a small trial of 61 patients where they used an esophageal probe to actually titrate PEEP to transpulmonary pressure, and they showed if you titrate it to a positive transpulmonary pressure greater than 0, that you actually have to use much higher PEEP, a PEEP of 20 rather than 10, but that there's markedly improved compliance and markedly improved, about a doubling of oxygenation. It's a very simple strategy. You put an esophageal probe down. We use a special ventilator to actually monitor transpulmonary pressures. And that was EPVENT 1, and EPVENT 2 is ongoing now, almost complete. This trial has an outcome endpoint rather than just oxygenation of mortality and ventilator-free days at 28 days. And it has the same strategy to achieve a transpulmonary pressure greater than 0. And the study design is excellent because both in the transpulmonary pressure group and in the group that is being managed by conventional ventilation, they have tables for oxygenation and pressure management. So it's very well controlled. So I question here whether this will be in our rescue strategy for the future. We currently use it because we are a part of the EPVENT 2 protocol sites, but I question whether this will be a possibility for the future. A word about the oscillator. The oscillator is not yet dead, but it's a little bit on a trajectory of mortality, and I'll show you where we are. We used to use the oscillator a lot, particularly in 2009 with H1N1. And part of the problem with the oscillator is that you pretty much have to heavily sedate or neuromuscularly block your patients. Really, the difference is no different than APRV or high CPAP. It's a high mean airway pressure strategy. Here's one of our trauma patients that came from Detroit, a 17-year-old who was 3 weeks postpartum, was a pedestrian struck, very severe ARDS. By the time she got to us, her saturations were 30%. Her PO2 was virtually unmeasurable, and she went on the oscillator and fully recovered. Here's her pre-FOV post. She was on it for 4 days. She got weaned to pressure support, got extubated 8 days after admission, and did well. We've had a very good strategy of recovery here with oxygenation markedly improved with HFOV. And we have identified that if by 48 hours you do not improve with the oscillator and your PF ratio still stays below 100, that your odds of dying are about 6% higher than if you're a responder. But basically, this is a responder to high mean airway pressure. It is important to have protocols. So right on the side of our oscillators, we actually have these protocols for how to manage ventilation and how to manage oxygenation so that the fellows and residents can be facile. We know in meta-analysis, just like nitric oxide, HFOV did improve oxygenation via high mean airway pressure. In terms of mortality, there was a signal for potential benefit. There were 2 trials that actually have made us use it less. The Oscillate trial, which we participated in, was a Canadian-US study that was stopped early by the Data Safety and Monitoring Board because of harm. And here you can see that HFOV was associated with a higher mortality rate at 60 days. And that was in part related to high need for vasoactive drugs with the high mean airway pressure. And so we still consider it as rescue therapy, but not as primary therapy up front. And then the OSCAR trial was the second trial, a UK trial that studied HFOV versus conventional ventilation. No difference in outcome. Notice the high mortality rates at 41%. So HFOV should not be used as a primary strategy in severe ARDS. It should be conserved only as a rescue strategy. And then finally, ECMO. So Michelle, 18 years old, lupus, severe septic shock. We can't really use recruitment. She's already on high PEEP at 20. She was a non-responder to nitric. She was a transient responder to prone. And so we quickly went to ECMO in part to reduce the mean airway pressure in her thorax and hopefully to get her heart to work a bit better. So ECMO is our end algorithm. It is part of the rescue strategies in the Berlin definition. I think everyone knows the CSER trial and its limitations in terms of randomizing patients to ECMO versus standard protocol. 22 patients randomized to ECMO did not get ECMO, and in the protocol control group, it was not standardized to low tidal volume ventilation. Despite the limitations of RCTs supporting ECMO, we see a big uptick in ECMO for acute respiratory failure in adults that started in 2009 with H1N1. This is the ELSO report that shows pretty much an exponential increase in ECMO for adult respiratory failure. And ECMO has changed from when I first went to the University of Michigan, that's on the left, and here we are now, a very streamlined circuit. We now keep patients awake, spontaneously breathing. We don't have an ECMO technician at the bedside. They just do rounds every 4 hours. A standard ICU nurse manages the ECMO circuit. But probably the biggest advance in ECMO has been the dual lumen cannula. And you can see traditional ECMO cannulation on the left here, where we put an inflow cannula into the right IJ and an outflow cannula into the right femoral vein. There is a lot of mixing or streaming, and here this is a problem in terms of optimal oxygen support, in terms of recirculation. On the right, with a dual lumen cannula just via the IJ approach, we actually are able to draw blood both from the IVC and SVC, and we can have inflow into the right atrium for oxygenated blood. And this cannula has been a great advance because it also allows our ICU patients to get up and around and be ambulatory. So this approach is placed by fluoroscopy. You have to position it properly so that that medial lumen provides inflow into the right atrium. We've established a fluoroscopy approach with an endovascular technique so that we don't do this, which is to coil the wire in the heart and possibly get a right ventricular rupture, as you see that wire coiling. This is a 31 French cannula, so it's like the size of a chest tube. So if you don't get it down into the IVC, you'll be making a perforation in the right ventricle, which is not good. And here's our approach that we've described to actually get it in the right place all the time by fluoroscopy. So here's Michelle. This is her 31 French cannula, distal tip in the IVC, medial port into the right atrium, deoxygenated blood coming out, oxygenated blood going in. A number of our patients here up and about, this gal doing a bicycle, exercising. So it's a very different strategic approach for ECMO today than it was in the past. And here's one of our patients prone on ECMO, feet down, trying to recruit the posterior lungs to get her off ECMO. We have one nurse at the bedside, and then we have another senior ICU nurse that is a scribe that just keeps the computer happy and keeps all the monitoring. So what data do we have for this? ECMO has been reported for acute adult respiratory failure as 50% all-cause mortality through 2006. But we are putting sicker and sicker patients on because many patients respond to those other rescue strategies. And so now we're keeping them on for much longer periods of time. Here's one of our patients on for 56 days, fully recovered. This is from the Karolinska Institute, a young patient with viral ARDS, a long ECMO run with no tidal volume seen at all for almost 2 months. Saturations of 65% for 45 days, and now fully decannulated, awake and alert. He was on ECMO for 68 days, full lung recovery. So we actually asked of our ELSO registry, how much does this happen and what actually is the survival rate for prolonged ECMO? Because a standard ECMO run is about 10 days. So we identified prolonged ECMO as anything greater than 2 weeks. You can see again the uptick here in prolonged ECMO from the ELSO registry. And suffice it to say that from 2007 to 2013, the mortality rate or survival rate here for patients with prolonged ECMO is about the same as for short-term ECMO, about 50%. So we're rethinking. Lung has unexpected regenerative capacity during prolonged mechanical support, I think similar to acute kidney injury. Late follow-up, the lungs fully recover. There is no COPD. There is no long-term problem with lung function. We have some new practical problems here in terms of how to keep that cannula in without creating necrosis, how to not make it bleed. But there are great opportunities for science for the future here. And here's Michelle. This is 1 year, her 1-year anniversary just this month. She went to her prom, and she's actually coming to the University of Michigan. We recruited her to the University of Michigan, and she's going to go to pharmacy school eventually, so we're really proud of her. She still has her ECMO scar. There is a trial that is ongoing, the Eolia trial, which is soon to be completed, that you should be aware of and be on the watch for. It's a multi-center trial. It will randomize patients to ECMO versus conventional ventilation with a crossover allowed for conventional ventilation patients to go to ECMO. And the conventional ventilation arm is very tightly controlled in terms of management. It has a mandatory use of the new CardioHelp system that is the portable device for standardization of ECMO. And then finally here, there is a position paper on how important it is to have worldwide ECMO support in terms of having standard centers who do this all the time. Lastly, it's important not just to have an algorithm for ARDS in hospital. We have one for transport because we send our survival flight team to actually go get our patients, and they have a similar one that we have in hospital. So I'll leave you with this. The rescue strategies in ARDS need a lot more study. We have no studies on combination therapy management, and there is a huge opportunity for science and advancement for the future. ARDSnet is dead. It has died. It's been retired, and the new network is the PEDAL network. We are fortunate to be one of the 12 clinical centers involved in this, and keep this on your watch as well for studies soon to come. I really believe, and I hope I have shown you, that an algorithmic evidence-based approach is very important and can lead to substantially improved outcomes compared to randomized trials. I want to thank the association and particularly thank President Scalea for the opportunity to give you my words today in an area that we are really passionate about at the University of Michigan. I hope it's been helpful to you, and I really thank the organization and the membership for this opportunity to speak. Thank you again.
allowed him. I had a feeling this would work out pretty well. Lena, thanks so much. Here is your Master Surgeon medallion from the American Association for the Surgery of Trauma. Thank you.